We shall now go on to our next speaker, Dr. Hemalini Samant, who's practicing in SRCC Children's Hospital. Dr. Hemalini? Yes, and again, a leading pediatric and neuro-ophthalmologist from Mumbai. She is going to be talking on evaluation of unilateral optic disc edema. I think a very important topic, preferred practice guidelines. I know she's going to shoot off in 6 minutes.
Thank you, Dr. Chitra, for inviting me. So the first slide is showing different pictures of disc edema, and looking at the fundus picture, you cannot reach a good diagnosis. So how do you reach a good diagnosis? So certain tips for a good examination. The first and the most important tip is that do not dilate without checking for RAPD. Why am I stressing on this factor is that most of the times the pupil evaluation and the workup is done by our optometrists who, and by the time the patient comes to you, the patient is already dilated. So therefore, it is very, very important for you to train your optometrist to do a good pupillary evaluation. When you're looking at the fundus, look at the perimeter of the disc, look for the obscuration of the blood vessels, check for the spontaneous venous pulsations, always examine the fellow eye for comparison. It will give you good clues. Assessing the optic nerve function, what I mean to say is always check for color vision. So what I've done is I've trained my optometrist that irrespective of what the history is, color vision is a mandatory part of the examination. Always do a perimetry wherever possible. Again, this point is important because a lot of us think that, okay, if the vision is very less in the affected eye, we don't need to do the perimetry, but we still need to do the perimetry to document what the situation is in the other eye. OCT, VEP, and B-scan neuroimaging are other tools for a good examination. So what are the causes? With pain, optic neuritis and arthritic AION. Without pain are dysdeucin, non-arthritic and neuroretinitis, and these are the other causes. My discussion will be restricted to just a few of these causes. So the first case is that of a 65-year-old, gradual loss of vision. Medical history was diabetes and hypertension. The vision loss was moderate. There was an RAPD. Fundus showed a disc edema in the right eye and a crowded disc in the left eye. Fields showed an inferior altitudinal defect. So this is what the fundus picture looked like. This is what the corresponding fields will look like. When you see this, you know your diagnosis is anterior ischemic optic neuropathy. What is the preferred practice pattern? Number one, perimetry is very useful to reach your diagnosis. Please remember that there is no role of neuroimaging in these cases. Role of steroids, very, very, very controversial. Most important thing is control the diabetes, hypertension, refer to the physician. All patients above the age of 50 years old, you must do an ESR and CRP to rule out an arthritic AION. Can treat with aspirin and anticoagulants, but is this going to help an ischemic event in the other eye? Controversial. What is new in AION? What is new in AION is don't treat AIONs with steroids or IV methylprednisolone. Pay more emphasis on correcting the lifestyle factors such as stop smoking, alcohol, regular exercise, good healthy diet, control the sugars and BP. If you come across a patient who has AION, who is progressively losing vision in absence of systemic risk factors, is a moderately obese individual, ask for history of snoring. He could be having an obstructive sleep apnea, and if required, you could do a sleep study. The next case is that of a 56-year-old, sudden loss of vision. Vision was 624, progressively decreasing. He did complain of headache, but when you have this kind of a patient, he could present with other signs like jaw claudications, fever, joint pains, etc. The ESR and the CRP were high in this patient, and the field defect was inferior altitudinal. The diagnosis was an arthritic AION because he had a chalky white pallor with disc edema. Now, this is the classical appearance, but the appearance of the fundus could be a little different. The preferred practice pattern is that ESR and CRP being high will clinch the diagnosis in most cases. They may have an increased platelet count also. Should we do a temporal artery biopsy? Well, not necessary in all cases, but can be performed when in doubt. But please make a note that a negative biopsy does not rule out an arthritis. Again, there's no role of neuroimaging except when in doubt and want to rule out an optic neuritis. Treatment is with oral steroids. If doesn't respond, you can shift to other agents, but the visual prognosis is poor in most of the cases. The next case is that of a 30-year-old whose vision loss was 624, sudden onset. The fundus picture is classical. You see a disc edema with a macular scar suggestive of a neuroretinitis. But the thing that you need to remember is that the macular scar may be incomplete or may take 7 to 10 days for it to fully develop. The preferred practice pattern here is neuroretinitis is never associated with demyelination. The commonest cause in our country is TB, syphilis, sarcoid, and toxome. No role of neuroimaging, and treat the cause along with steroids. The next case is that of a 32-year-old, classic history, high hyperopic, vision is 6.6, plus 6 was the refractive error. And if you take a look at the fundus picture, it really looked like an elevated disc, and one can get mistake this one for a papilledema. So the other investigations that you would perform when in doubt for a disc drusen would be a perimetry, B-scan, autofluorescence, CT scan, OCT. Always look for the spontaneous venous pulsation, although absent in 20% of the normal population, but its presence definitely rules out a papilledema. The next case is that of an optic neuritis, which I'm not going to touch on because there's another talk on that. The only thing that I'd like to highlight in optic neuritis patients is that do not do a CT scan to come to your diagnosis. Do not treat these patients with oral steroids, and there's no role of retrobulbar injections of steroids. Thank you.
Thank you. That was a wonderful talk.
Thank you, Hemalini. Excellent talk, perfectly on time, covering up the key points that we would want to make. Thank you. Dr. Shikha, for unilateral disc edema to come to a kind of diagnosis, how much would you use or trust the OCT for? Now we're struggling with ischemic, neuritis. So would OCT give us a little bit of idea before we start, planning?
Mic.
Could you pass the mic?
Excuse me, one more mic you can give.
No, he's given.
Research phase, but very subtle things can help us in differentiating between. Most of the time the DDs are the ischemic optic neuropathy, neuritis, and a disc drusen, that is pseudopapilledema. So drusen, obviously now with the consortium showing what the drusen looks like, if it's there, and sometimes you can have drusen and ischemic optic neuropathy. So you can, it can tilt the diagnosis towards one side. Whereas in, if there is presence of subfoveal fluid along with that, then again it, tilts the diagnosis towards ischemic optic neuropathy. And in case of optic neuritis, sometimes the other eye also will show, some thinning. So definitely it can be used, but you can't do an OCT and tell that, that shouldn't be your mainstay. The main thing should be the clinical evaluation history and everything, but it adds, it gives you extra information, I'd say.
Can papilledema be an asymmetric presentation?
Yes, the drusen sometimes.
Okay, he'll talk.
So I'm sure Rashmi will cover
Sorry,
that up wonderfully.
Sorry,
Thank you, Dr. Shikha, and I hope more research that you're doing on OCT will help us make our life easier, which is getting very difficult now. But